So, I think we are all familiar with this study, and the main surprise is not much what you see on the right side, the difference in big vessel, but stents in small vessel do not perform so well. If you see, the difference is inferior when you place a stent in a small vessel compared to a large vessel. Why even good DS do not perform so well in small vessel? So I think no reason to use DCB in small vessel. I think the evidence is quite overwhelming. But I think in big vessels, we have to recognize the stent do pretty well. So in my view, I don't see the reason to randomize. I think we have to use DCB in some situation when possible. Otherwise, use DS, because it would be not easy generically to match stents. But let's go back to the small vessels. Why stents don't perform so well? We have to go back to 1998. We wrote this paper at the time of bare metal stent, no DS, angiographically comparing a small vessel and large vessel. And you see that the late loss in a small vessel is higher than the late loss in large vessels. You can speculate why, but when you place a foreign body on a small vessel, the tax rate that you pay is higher than the tax rate that you pay when you do it on a big vessel. So I think this is attenuated, of course, when you have a drug on the stent, but I still believe we don't have really studies comparing DS, but I think you still have the same phenomena, that the tax rate is higher when you place a stent on a small vessel. So why DCB and DES perform the same in small vessel? In small vessel, the amount of metal is too much for the vessel area. That may be a reason. Suboptimal DES implantation is more frequent in small vessels. In large vessels, people are more prone to do IVUS to optimize. In a small vessel, mainly they get rid of the stent. The success is that the stent is not anymore on the balloon. That's it. So, but why we want to replace DS in large vessel? We always are upset about caging. When DS are optimally implanted, events are very low. Majority in DS in real life are suboptimal implanted. And the reason why, because DS are very forgiving to suboptimal implant. But we have to acknowledge that optimal implanting a DS is not free of complications. Even if you look in the Lumen 4, optimization was associated with a numerically higher complication than no optimization. So I think there is also some reasons not to be concerned to optimize the stent, because sometimes you pay the price. But we always say that lesions treated with DS have sustained event during follow-up. But what kind of evidence we have that replacing metal with a device allowing remodeling and vasomotion will impact on future events? This is the working hypothesis, but I must say that we do not have any evidence. But when we analyze the cage-free, we look at the subgroups, and you see in elderly people, the difference is not as favoring DS as in younger people. When you go with chronic kidney disease, the same. Bifurcation lesion. And so there are some multivessel disease. Only the proximal LAD really perform very well with DS. So maybe instead of concentrating on simple lesion, we have to concentrate in complex situations, because that's where drug-eluting stents do not perform so well. If we exclude from cage-free the proximal LAD, the difference becomes less marked. So I think I understand that if you have an optimal result, why implanting a stent even in the proximal LAD? But I don't think the efforts should be in this direction. So in most lesions located in vessel 3 mm or larger, if well implanted, DS perform well. We need to find, as Thomas said yesterday, we need to find the sweet spot where DCB usage is more advantageous compared to DS. And the boundary of these sweet spots are not fixed, but at the present time to do a generic trial of DS versus DCB in large vessel, to me is not appropriate. And I would say 3-vessel disease, bifurcation lesion, including the left main, long lesion, ostial lesion, total occlusion. And the concept of DES crossover should not exist. PCI with availability of DCB. Let's go some examples. This left main, the disease in the circumflex, in the old time, we used to consider 2 drug-eluting stents. Nowadays, after having implanted a stent on the LAD, kissing, the circumflex is excellent. So these are typical lesions where you don't want to implant a stent. These ostial circumflex is typical. If you implant a stent, you get carina shift. You get away, of course, but why make your life complicated? If you do DCB, it's much easier. These trifurcation, if you don't have DCB, where do you implant a stent? In one of the 2 branches, then you have to do kissing, that you have carina shift towards the LAD, you make your life complicated. With DCB, everything becomes much more simple. You don't even touch the LAD, and the procedure becomes much shorter. These left main, of course, in the left main calcified, you implant a drug-eluting stent, but in the circumflex and in the 2 spots of the LAD, you do DCB. So again, you have to use DCB selectively. These long diffusely diseased LAD, you can do it without stents at all, but maybe what's wrong? Implant a 18 or 20 millimeter stents, 3.5 very proximally, and then you do 2 drug-eluting balloon in the mid and in the distal LAD. This is one final result and a 1 year follow-up. Diffusely diseased LAD with long lesion, we really like to use a PDPA. We like to use PDPA because we monitor what's going on during the procedure. This is a baseline PDPA. You don't need, of course, FFR when you have a PDPA like that. It looks like a ventricular curve. And then you start, you can work with 1 wire or you can work with 2 wires. You monitor what's going on. You do the pre-dilatation, and after 2 or 3 dilatation, look, the PDPA is already much better. You know that the wind is going in the right direction. So at a certain point, you don't need any angiography. Just follow the PDPA. When you reach a stable 91 and 92, you know that the result is acceptable. Of course, as I said at the beginning, this proximal LED, most of the time you implant a stent. But what's wrong? If you do a pre-dilatation, you get a good result. There is a linear dissection. You do IVUS and you check the lumen. The true lumen is very large, and that's our criteria by angiography. Not much the presence of the dissection, but how large is the true lumen. If you dilate it with a 3.5 balloon, you need a true lumen at least 7 or 6.5, and if that's the achieved true lumen, you are done. So what we need, I think, as I said yesterday, we also need an objective and practical approach to evaluate the result. As I said yesterday, residual stenosis less than 30% is too vague. Maybe PDPA, I don't know if the answer, but in this day and age, we need something more precise than 30% residual stenosis because it's too vague. So DCB for small vessel, established field, no reason to do another trial. DCB in large vessel, I think is in evolution, but do not believe to replace stents in large vessel, but try to find the appropriate area. Thank you for your attention. These are several.